behalf of the TNOA Ophthalmic Committee, I'm very glad to welcome you for this wonderful program on Heart Care for Eye Care by Dr. Priya Chokkalingam. And this is one of the commitments made by our president, Dr. Nirmal, for the holistic well-being of the TNOA members. And we are very delighted to announce this program for you. So let's pass on the baton to Dr. Aravind, who is going to be the anchor. Dr. Aravind, please.
Aravind, over to you. Unmute yourself, Aravind. Sai, could you unmute Aravind?
So this, just I want to add, this is going to be an interactive meeting. So you can directly ask a question and answers to Dr. Priya and learn about lifestyle modification, risk assessment, and mitigation of heart health. So this is going to be a very interesting meeting. So make sure that you keep your questions ready so that we can have a very nice interactive session.
I guess
Nirmal
I'm
sir, are you?
Yeah.
You're unmuted, Aravind. Just a minute. Nirmal sir, are you okay for a couple of words? Is your signal okay? No, I don't think so. Because, yes, he's unmuted.
I am
yes.
still traveling, Sriram. Please
Okay,
go
sir.
ahead.
No problem. Yes,
So welcome
sir.
all
No
of
issues.
you. Since I'm traveling, thank you,
Yeah.
Sujata madam, for taking the baton and welcoming the audience.
Yeah.
And it's over to Aravind now to take care of the session. And welcome our speaker also. Thank you so much.
Yeah.
Thank you. Thank you. Look forward to an interesting, invigorating session.
Thank you to our president, Dr. Nirmal Frederick, sir, for this new concept of wellness as a priority for our members of the TNOA. Thank you, Dr. Sujata madam, for starting up the show. Thank you, Dr. Sriram Gopal, for initiating this meeting. And of course, thank you, Dr. Priya, for joining us and contributing your time. I know your interest in preventive medicine for cardiac health. And I have the pleasure of introducing you to this audience. I'm sure you're very popular among cardiologists, but among the eye doctors, I get the privilege of introducing you. Now, Dr. Priya comes from a very illustrious family of cardiologists. Dr. Chokkalingam has been the cardiologist for the previous Chief Minister, Dr. MGR, and multiple famous personalities. And Dr. Priya has taken up the baton of preventing people from going to the cardiologist by introducing a lot of knowledge and lifestyle measures into modifying people's habits and empowering them with the knowledge which will enable them to take care of their disease and probably take health into their hands. And that is something we, I think, share common interest in. Dr. Priya is an alumnus from Madras Medical College. She's also worked extensively in the field of cardiogenetics, and she shares her knowledge through the Cardiac Wellness Institute, which she is the founder director of. And she has written multiple books. Some of the books that she has written for the public are Journey to a Hearty Health, Mind Your Heart, and Idayam Kaka, which is in Tamil. Apart from this, she has also 30 peer-reviewed journal publications, and she has contributed to 3 textbook chapters. She also has 40 national, international scientific presentations, and she's a very sought-after consultant in Kaveri in the field of preventive cardiac health. So with these words, Dr. Priya, please welcome to our small attempt at increasing awareness on cardiac issues.
Thank you. Thank you very much for that kind introduction, Dr. Aravind. I hope my audio is clear.
You're quite clear. A couple of things about the webinar itself. So this platform, everybody who wants to question can actually join as a Zoom member. But when they have a question, they can type in the comment box or they can raise a hand. Then the Numerotech, the backend team, will help them raise their question. If they want to type in the chat box, they can type and we can ask their questions. If they want to voice out their question, they can raise a hand and we will unmute and go ahead. So this is a very novel attempt where we want to keep it interactive and also restrict ourselves to the constraints of time. So we will be to the point. Some of the questions have already been posted to me. So I'm going to start shooting the questions. That's the easy part. So Dr. Priya, are you ready?
Yes, before that, a very big thank you also to the TNOA for this, I think, wonderful opportunity to meet up and discuss and interact with my ophthalmology colleagues. Dr. Aravind, they've already had one session, I think 5 years ago, where we did heart to heart, and we had a great session. We were active, we were doing some fun stuff. But I'm really hoping that your initiative, the TNOA's wellness initiative, is going to do a lot of wonders. And I'm really glad to be the first or one of the first, people to participate in this show. Thank you. And yes, and I'm ready to take your questions.
Indeed. Thank you for bringing it up to our memory. Actually, in 2019, the pre-COVID era, we conducted an open air event, and Dr. Priya was very kind enough to come and offer a talk on cardiac prevention and lifestyle modifications to our audience of eye doctors. We had about 40 people strong who took part in both the outdoor and the indoor event. So thank you again for our constant association. So this is going to be lively. So I'm not going to be scientific. I'm going to be a very lay person who's going to shoot questions straight out of my heart, basically. So we keep hearing this in the news all around that, there are deaths because of cardiac illness, sudden events where people were working out or people were doing a particular activity and suddenly they had a massive myocardial infarction or a heart attack. These really grab the news. Of course, atherosclerotic cardiovascular diseases have increased in incidence and they are now one of the top killers in the world. Statistics in the US, we don't have very reliable Indian statistics, but I read that American statistics say that one person dies every 35 seconds of a cardiac illness. Now that is quite shocking. So what is your view? Has cardiac disease increased in number, or are we just seeing more of this right now?
Wonderful question to begin with. So there has been definite evidence to show that non-communicable diseases, particularly cardiovascular diseases and atherosclerosis, as you just mentioned, or coronary heart disease, as we would like to call it. So this spectrum of diseases, including the other non-communicable diseases. So basically, non-communicable diseases have taken over in terms of mortality and morbidity. So I do have a few slides to share, but first things first, NCDs are at top of the list now. And if you want to say the top 10 killers, number one, unbeatably number one is coronary heart disease. And that being the case, more and more youngsters, particularly people in their 20s, 30s, and 40s. So this was the age when we thought coronary artery disease or atherosclerotic heart disease, MIs, myocardial infarctions, do not commonly occur. So we were, at least when I think we are all counterparts, and we went to medical school, we were taught that it's a disease of predominantly men in their 60s and above, or at least 50s and above. Unfortunately, it's not the case anymore. It's a common disease to all genders, and it's the number one killer in men and women. And particularly the age at which the first heart attack occurs is at least 2 decades lower in Indians as compared to the Western population. So does that mean communicable diseases have been controlled? I would say in a way, yes. We have had very good, records of vaccinations and antibiotics and so on and so forth. So we have actually had a good grip or a good control over communicable diseases. Again, I will show shortly in a couple of slides. However, the COVID pandemic was and out of the blue, it came and it caused a lot of havoc. But, let's ignore that freak pandemic. But then in general, communicable diseases have been on the decline, but non-communicable diseases, and more so coronary heart disease has been, taking the upper hand and has been very devastating in the last few decades. Let me just share my screen for a quick couple of slides. Yeah, so when I'm not actually, seeing patients or doing academic stuff, this is what I'm doing. So I'm quite a nature person, nature enthusiast. So hiking or biking, bird watching. I did try running, long distance running. I did a couple of 10 kilometers and I said, okay, that doesn't look like my cup of tea. So I'm not pursuing that much. But yes, I do high intensity interval training. I love badminton. So I just try to keep it varied and try to keep it active as well. So non-communicable diseases have definitely become the top killers. If you were to look at just this slide here, you see that, for instance, deaths due to diabetes and hypertension in the year 2020, that's like almost 3 years ago now, the deaths have actually increased about 500% in diabetes. So it's basically says from 2000s, the number of deaths per year have gone up to 16,000. And if you look in the bottom panel, the deaths due to infectious diseases, let's say malaria, typhoid, diarrhea, hepatitis A, all of those have actually come down in a very remarkable manner. So there's been a significant decline in deaths due to these communicable diseases in India. So again, this slide very, specifically shows that non-communicable diseases, and particularly if you see down there, cardiovascular diseases per year, we are having at least 25 to 30 lakhs is definitely an underestimation. These are the reported cases. So we know that in India, there's a lot of gap between the actual deaths and the number of reported cases, but this is what it is. So put together, almost 2/3 of all deaths in our country are caused by non-communicable diseases. So we have a big issue at hand, and yes, heart attack deaths are going, soaring above the roof. So like recently in the last year or so, it was about 33,000 people per year. But then again, this is an underestimation, right? And this graph very clearly shows that across different states, whether they're less developed states or, even highly developed states, like for instance, Tamil Nadu, we are categorized as a highly developed state. Across the board, communicable diseases have gone down compared to 2 decades ago. In 1995, and this is of course a slightly older statistic of 2014, but nevertheless it very clearly shows a declining trend of communicable diseases and a very sharply rising trend of non-communicable diseases. And finally, this slide is just to show the that we are, as a state, Tamil Nadu and Kerala, so southern states and 1 or 2 northern states. So Tamil Nadu is at the crux of this problem. We have cardiovascular disease in the top panel, on top left, and then ischemic heart disease, so particularly coronary heart disease. Of all the cardiovascular diseases, coronary heart disease is the biggest killer. And again, you see that Tamil Nadu and Kerala are topping the list, right? So the Tamil Nadu, as our colleagues in the Tamil Nadu Ophthalmic Association, even the cardiologists in and around the state, all of us should be aware of this, sensitized to this, so that we are able to address this issue. So if you see the C and D panels are stroke and rheumatic heart disease. Here we are faring much better than other states, a few other states, but it's the cardiovascular disease and coronary heart disease where we are having a huge problem. So yes, I'm going to stop my slide share now. Hope that message has come through clearly. We have a huge problem at hand, and it's the younger people who are actually facing the brunt of the disease these days.
Yes, thank you for putting that into relevance, because I think it's alarming. And at the same time, I think it's a wake-up call that we take this problem head on and we start doing stuff so that we can probably change this trend. Absolutely. So you again said that younger people are probably getting more of this condition, and we are seeing younger people who were previously probably protected but now seem to be more at risk. So why do young people seem to suddenly have an increased incidence? Is it a change in lifestyle? Is it a change in the disease profile? And I would also like you to talk about sudden cardiac death. Every time we read it in the news, it is disturbing. It makes you stop and think, whether we are actually getting better in terms of technology, or are we regressing? So
Sure.
your
Yes.
views.
Yes. So I think, yeah, two important things here that probably young people were dying even earlier, but now there's so much more that's happening in terms of a rat race of a lifestyle, right? So people have, I think there's been a lot of mismatch between what is expected out of the youngsters in life and what reality actually is. So basically, lifestyle issues play a very important role in the causation of sudden, cardiac arrest or myocardial infarction in the young population. But let's clarify the term sudden cardiac death first. So because we read a lot, as you said, it comes up in the news, it comes up in social media that somebody who's very healthy and active, and in fact, maybe a gym goer, a fitness enthusiast suddenly drops dead. So people among the public are like worried. Is it because this person was exercising? Was the death caused by the exercise? Should they stop abruptly all forms of exercise? And, so these kind of myths. So anyways, what is sudden cardiac death? Basically, sudden cardiac death refers to any unexpected death due to a cardiovascular cause that occurs within 1 hour of onset of symptoms. So this is a very rapid event, and from the start of the event to the actual death itself. This is in case of a witnessed event. In case it was unwitnessed, then any death which occurs within 24 hours in an apparently healthy individual would be called a sudden cardiac death. So if this individual had the opportunity to get resuscitated and is maintained alive, then we would call it a sudden cardiac arrest or a resuscitated sudden cardiac death. So this is what sudden cardiac death is, and the causes for this are many, right? So again, I think a few slides will help to clarify the causes of sudden cardiac death. Are you able to see my slide? Not in
Yes,
full
we can see your slides.
I just put it in full screen. Yeah.
Absolutely.
So if you see a biggest chunk of the causes of sudden cardiac death, about 75% is coronary heart disease. Yes, that is a very stark, big majority being formed by coronary heart disease. So, but what is striking is we cannot rule out or we cannot confirm that anybody who dies suddenly or who's faced a sudden cardiac death has had a coronary heart disease without exploring further or investigating further. Because of the remaining 25%, we have different sets of diseases, mainly cardiomyopathies. Okay, so for instance, you would have heard of dilated cardiomyopathy or hypertrophic cardiomyopathy or arrhythmogenic right ventricular, ARVC as we call it. So there are different types of cardiomyopathies. Here there are some structural abnormalities of the heart. They are almost always inherited or genetically, transmitted to the individual. So these conditions have to be investigated in a genetic manner through genetic testing. So again, if you see about 2% of these conditions are caused by inherited arrhythmia syndrome. So we call them as channelopathies, abnormalities in the ion channels of the heart, like long QT syndrome, Brugada syndrome, CPVT, etc. And again, a smaller proportion, valvular heart disease, and a few other coronary abnormalities or coronary artery structural abnormalities, etc. So there are about 25% of cases which may be due to other causes. We cannot club all of them together as a heart attack, as an MI, right? So that's one important message there. Again, sorry for the not very clear slide, but again, here the premature coronary artery disease is a big issue which is being researched all over the world. And Indians are again at the top of the list there. So they have a lot of cases of premature coronary artery disease. Here in India, we are facing, as we say, 25% of our MIs are people who are below the age of 40 years. Okay, if we take 100 cases who present with MI, about 25% of them are less than 40 years of age. So this is an age where there is a clash, there's a confounding effect. Is this, purely MI due to genetic problems? Is this due to lifestyle disorders? Is this not a coronary artery disease at all? Is this cardiomyopathy? So on and so forth. So there are so many questions that need to be addressed. However, of all the premature coronary artery disease deaths, we found that 90% were male. So these are some important statistics. Males were more who had coronary artery disease, sudden cardiac deaths. 60% were smokers. Yes, so the common risk factors are showing up here: hypertension, diabetes, low, HDL cholesterol being low, that's the good cholesterol being low, abdominal obesity, and even elevated triglyceride levels. So these, common risk factors that we know about are still, playing a role in sudden cardiac death in youngsters as well. But again, if you look at this graph here, I just want to focus on how at around the age of 20, that's the prime of life in their early 30s, let's say 30 to 40, you start seeing a steep rise in the number of young lives lost. So basically, these are young people who are dying due to cardiovascular diseases. And then it starts to rise sharply. And of course, you see that the peak is in the 60s and 70s as we know it. But again, the start or the peak starts much earlier than we thought about it. So this was, again, one important illustration from the US. So basically, they looked at sports-related sudden cardiac arrest. So you're asking me, why is it that our young people are dying in the gym as they're exercising or as they're playing sports? So sports-related sudden cardiac arrest is an important, aspect of cardiomyopathies and channelopathies, or as I said, inherited arrhythmia syndromes. And it can also occur in somebody who has a coronary artery disease, but more so, you would know people with coronary artery disease because quite often they present with symptoms, right? We know that they would have angina, they would have exertional angina, some kind of symptoms to denote that their coronary arteries are compromised. Whereas in cardiomyopathies or channelopathies, they might not have any symptom at all. The first symptom itself might be a sudden cardiac death. They might have had some syncope in the past, that is intermittent loss of consciousness, short periods of loss of consciousness, and they recover themselves very quickly. But if this is not investigated, so they might think this is, syncope, or the child just lost consciousness because the child didn't have breakfast, or the child was, made to play in the playground for a long time under the sunlight. So these kind of myths are all there. So any young individual with a syncope or a loss of consciousness, the bare minimal that should be done is an ECG. An electrocardiogram has to be taken in these young children or adolescents. So what you see in this graph is between 2005 and 18, the number of sports-related sudden cardiac deaths have been quite static. It's been about 60 per year or so. But what has gone up is the use of AED, that's defibrillators, the automated external defibrillators. Bystander CPR has gone up, and therefore the survival to discharge. So those who would have been declared as dead as sudden cardiac death have now gone on to become survivors of sudden cardiac death or resuscitated sudden cardiac death. So this is again something which I thought is important for our ophthalmology colleagues to recognize. Yes, all sports-related or gym-related deaths should not be concluded as MIs. We need to go into the family history, initially into the clinical history of the demised individual itself. If possible, try to recollect and recall some of their previous ECGs and look at their reports. Try to get their family members, at least their first-degree family members like siblings or children or parents, clinically screened or investigated. And then if deemed necessary, go in for a genetic test. There is also a concept called a molecular autopsy. A good postmortem has to be done in a center with a cardiovascular expertise, and blood has to be retained for a genetic test as well. So this is called a molecular autopsy. Yeah, let's move on, because otherwise there'll be too much of information that I give on cardiogenetics, which might become too confusing for the audience. But I think that this message should be, because we're all medically aware, and we should be the proponents of proper evaluation of these individuals, and not just take somebody saying that it's a MI, it's a young MI, and then leave it at that.
Thank you very much. Those very interesting statistics. And as a take home, and I think this is really a hot topic, so I will just try to reiterate what you said and what I understood, that a sudden cardiac death is not to be something which should be closed and forgotten, but we should investigate for what could have been a possible cause, not just the preceding event, but what was underlying in that young person's heart, and probably screen the family for any similar conditions, and definitely not forego an autopsy or a molecular autopsy to confirm the causes. And if there are any preceding events which could probably raise suspicion, not to trifle with them, but to actually follow up and screen up them.
Absolutely, Doctor. Absolutely, Dr. Arvind. That is the only way we could prevent further deaths in the family. So there have been instances where 3 or 4 children in the same family have died because of, not going through a proper evaluation, or the family being in denial. So, medically they have been advised, but the family is quite often in a lot of trauma and denial, and they would not even submit themselves or the other remaining children for testing. But I think there's a lot of counseling that needs to be done. So I think we need to recognize that these are difficult moments for a family. I mean, any death is, but more so when a young unexpected death occurs, it's so much more important to be compassionate and also to counsel them appropriately.
We have a question from the audience, Dr. Shirisha Gijari. I am not sure if she's a doctor or a non-doctor, but the question is quite relevant. She's asked if you can tell us about screening of young population to prevent sudden cardiac death, especially if they're non-symptomatic. Would you do a mass screening? What would you recommend for young people to prevent SCDs?
I think that's something we will be discussing as we move ahead. But, given the fact that coronary artery disease is still the biggest chunk of any sudden cardiac death, we should be aware that above the age of 20, everybody should have their normal testing for, let's say, blood sugars, hypertension, dyslipidemia, all of these done. So I think that's so very important. We cannot ignore these aspects. And I think, do you want to go into the full aspects of testing?
That is my following question. But anyway, because it's an audience question, I thought I would take it up. And it's quite relevant to our next topic too.
Yeah.
And I would like to note again that you have lowered the bar at age 20. There is no longer waiting for your 40th birthday to get your health checkup done and screen yourself. Age 20 is probably the new cutoff. And at your 20th birthday, I guess you should get all this screening done. So that's quite a take home.
Right. So from the age of 20, they say you get your first basic cardiovascular testing done. And if everything is okay, it's once in 5 years. And until the age of 40, you do, so for once in 5 years, that would be, you will get it at least 4 times between the age of 20 and 40. And then after the age of 40, it's every year or at least every 2 years. So that's very important to note. And because age 20 is now important, because that's the age when behavioral risk factors are picked up earliest and, best chance of addressing them, modifying them, let's say quitting a habit of tobacco smoking or tobacco use, or behavioral changes in terms of dietary intake, exercise, and mental stress. All of these things start to kick in at that age. So at this point in time, it's the age of 20 that the American Heart Association, recommends for your first screening. And that's right. But when you talk about sudden cardiac death, or I think our colleague had asked about, more tests for sudden cardiac death. Yes, there are definitely more tests. And for instance, as I said, an electrocardiogram, a simple 12-lead ECG gives a wealth of information as to what could be wrong with that person who's had either a sudden loss of consciousness or a ventricular arrhythmia, let's say. So a simple ECG that might lead on to an echo test, a Holter test, a treadmill test, and if necessary, a coronary angiogram to look at not just the coronaries, but also if there are any coronary artery structural abnormalities. And finally, if necessary, MRI scan and so on and so forth. And then if we really think necessary, a genetic test. Again, genetic test is something which is more accessible these days, much less expensive than it was 10 years ago. For instance, a targeted test to look at all the different types of cardiomyopathies is about 15,000, 15K, which is not much. If you look at, they would spend a similar amount in a CT coronary angiogram or something like that, right? So it's not a very expensive test anymore. In fact, if we identify one family member with a genetic condition, then then the same test can be repeated in other family members at 1/10 the price. So because it becomes a very targeted test. If we know that this mutation is there in, let's say, patient A, then the sibling of patient A, the children of patient A, the parents, the second degree family members, all of them who after initial clinical screening will also get benefit with a genetic test. We can rule in or rule out the disease and then prophylactically treat them if necessary. So that's how we take it forward for sudden cardiac death.
So since you brought up this topic about testing, now there are a lot of tests. There's also a huge population. And so what would you recommend that people start out with? Does family history play a role? How should somebody who's apparently normal at 25, what should they start looking out for? When should they meet a doctor? Is it necessary to meet a specific specialist? Like meeting a cardiologist is really up the scale. And in India, we have this habit of jumping towards specialists. Should they talk with their physician? Who should be the right person to contact, and what should be the proper protocol of testing? Could you just touch upon that?
Sure. Wonderful, Dr. Arvind. So first things first. So 3 simple things that everybody will have to ask themselves before even going to the lab to give some blood sample or doing an ECG is, are they exercising enough? Are they exercising properly and adequately? Second thing is, are they eating the right kind of diet? And third thing is, are they taking care of their emotional well-being or mental health? So these 3 questions are not often asked, or I would say they're kind of ignored, even by a cardiologist. I mean, as a preventive cardiologist, that's what I predominantly do, because without this information, looking at your, let's say, your blood report or all your fancy reports is not going to be of much use to me. So these basics things, we get the information through a questionnaire. So basically, it's the individual who responds to these questionnaires, and it's in simple language. So the ultimate message here is, if these are all independent risk factors, right? We just like how diabetes, hypertension, cholesterol abnormalities are definitive risk factors. Also are, of course, tobacco use, alcohol abuse and all of that, obesity. People are all aware of these things, but they're not even thinking about what lifestyle choices on a daily basis leads to these kind of risk factors, right? So ask yourself these questions related to exercise, diet, let's say sleep, and stress management. So once you have an idea of this, so let's say all your blood parameters, just like we just talked about, your BP is normal, your fasting sugars are normal, your cholesterols are well within normal limits, you don't have any bad habits, meaning no alcohol abuse or no tobacco. But despite all of this, if you're not somebody who exercises enough, or who is eating junk food, or not eating the right kind of food, or untimely diet, or is overstressed, or not getting enough sleep due to not having a work-life balance, all of these these 3 are the soft risk factors, as we would like to call it, but they are invariably independent risk factors for myocardial infarction. So I think before starting off with what are some questions that I can ask myself is the first thing. And then, yes, the second step is getting some corroboration in terms of your hard risk factors, okay, and also taking it up with further testing if necessary. As I said, if there's a necessity, we are going to go in for a treadmill test. I'm sorry about that. Yeah, a treadmill test, or let's say you want to look at your coronary artery calcium levels, okay? CAC is what we call it, through a CT angiogram. So, but these tests are best done after consulting either your family physician or somebody, or a preventive cardiologist that So basically, it's not that you really need to go to a cardiologist initially, but somebody who knows about these tests and what the interpretation of these tests, you need to have a discussion with them. And almost always in the early stages, lifestyle modification is all that is needed. That is why it's important to catch early stage diabetes or pre-diabetes or borderline hypertension early, because we do not need medications for these kind of early stages. We just need a 6-month good trial of lifestyle modification. And believe me or not, about 95% of our population converts into normotensive, normoglycemic or euglycemic status. The lipid levels normalize within those 6 months. And only if necessary, really necessary, we also take the help of medications. Give me 1 second.
Feel
My
free to drink. I am also holding my bottle. Since
Sure.
you-
So, am I clear on that?
Yes, you are. In fact, I'm really happy that you brought in lifestyle as your first intervention, especially when you're talking about lifestyle-related diseases and NCDs taking up such a huge chunk of preventable deaths. And I think my favorite now is these triple E's, like you said, exercise, eating, and emotional health. So if you mind your E's, I guess that's probably the first check. I really think that's a very valid point. And right now, across the board, we have a serious imbalance in these things. We live in a time of abundance in terms of the availability of food, the variety of food, and lack of exercise. And simple things like I remember, I'm sure you did too, that we used to walk to school or cycle to school. Nowadays, walking is something we do, as a structured activity. It's not something which we just do casually. So, and in fact, in our group, in our doctors group, we had a 1-month step count challenge, and people who hit 10,000 steps every day for 30 days were recognized. And out of about 35 people, nearly about 26 people managed to do 10,000 steps. So a new habit was formed, a new lifestyle intervention was done. So I'm really happy that you brought in that aspect. Of course, when you cross into that and you're not checking these boxes, I guess then blood tests, self-evaluation, meeting your physician, and then taking things forward, I guess definitely becomes relevant. But putting your first tick boxes into place probably makes a lot of sense. So here is another question. R. Divya, I think this is Dr. R. Divya, whose question is, how much is HSCRP reliable in predicting atherosclerotic disease?
Yeah.
Would you like to take the question? Yeah.
Sure. So basically, high sensitivity C-reactive protein, it's a marker of inflammation in the body, right? So now there's a lot of research that shows that basically atherosclerosis and all kinds of coronary artery disease are set in motion or initiated by the inflammatory process that goes on. More so during the pandemic. So we did see that, I think we have been seeing that there's been a lot of overlap between the COVID-19 pandemic and coronary artery disease, or let's say different kinds of cardiovascular diseases propping up in people who have had COVID-19 infection as well. So I think HSCRP is definitely a good marker for inflammation, for, let's say, it's more of a broad marker. So if you were to ask me, is this individual, just the fact that HSCRP is high, is this individual going to go for a heart attack in the near future? I mean, that's still a black box. We don't know for sure, but we know that there is some kind of inflammatory process going on in this individual. So we need to be more aware that, this individual might have also all the other cardiometabolic risk factors, like maybe diabetes, maybe some other kind of inflammation that's going on as well. So, but yes, it has been shown that it is important, but we do know that the specific biomarkers, there are some specific cardiac biomarkers, but that's also only for those who are actually going through a myocardial infarction that we actually have to look at those. So good question, but it's not like, a direct, I wouldn't say that, yes, HSCRP being high is going to put this individual at a high risk, but I think it at least alerts us and would be more important to see what other things might be going on to cause this HSCRP to be high, and then to make those necessary start taking the necessary steps to bring it down. And of course, only go on with further coronary artery evaluation if necessary. If we think it's important, then yes, we could go ahead and do more advanced tests. But it's an important marker. But again, I would not give so much importance to it that, that I would immediately put, let's say, to all those individuals with HSCRP, high CRP, then go on and do their angiogram. That's not how it works.
I understand. It's too broad a spectrum, I guess, with CRP to actually be predictive of cardiac illness.
Right.
And I also understand that inflammation by itself could be putting people at risk for arteriosclerosis in the future, and probably controlling inflammation through controlling or stopping smoking and stopping other inflammatory pathology could probably be more predictive than just using one biomarker for screening as a tool. I understand. Since there is so much of focus on lifestyle modification, shall we talk about how we could go about and what would be your top tips to our audience about lifestyle? What is the most relevant lifestyle modification you would recommend?
Great. Yeah, so I mean, once we think about prevention, so I think that itself is one of the best gifts or things that you could do for yourself. Don't wait until, quite often the attitude is it won't happen to me. And the second thing is, even if it happens, or whatever, people feel that they're super resilient, which is not the case. So given the fact that now anybody across the board can get an MI, and especially if they have even one of those different risk factors that we spoke about. So thinking about prevention is the first step, and proactively starting to do things on a daily basis, on a routine basis as to, I mean, it's not to scare people. It's not to say that they have to be over obsessed with, oh, I'm going to have a MI sometime and I'm going to do something about it today. That's not how we look at it. What can we do better in terms of, our physical activity? So we are actually designed to be moving, quite a lot of the time that we are awake. But unfortunately, as Dr. Arvind had rightly pointed out, technology has taken the upper hand. We're all, for instance, seated most of the day or our working days. And even that, sitting is called as the new smoking, right? People now know that smoking is not good, but they don't realize that just being sedentary, sitting down for hours together is in fact very detrimental to overall health. So first things first, try to be moving as much as possible, moving to work, let's say, moving as leisure, moving as part of your daily activities. So try to incorporate as much of movement as possible into your daily life. And take the help of, expert like a physiotherapist or a trainer, just to understand what will work best for you. So not everything works for everybody. So I might say, the universal standard is walking, right? So not many people enjoy walking. They're like, doc, I mean, you might as well kill me. I don't like walking. Okay, so it's not like, so it's not like everybody enjoys it. So for those who, I think predominantly people don't mind going for a walk, but if you ask them, do they really enjoy it? They might like think about it. Maybe not. They've been prescribed for us to walk. So try to, explore different things, because I'm sure this audience is a young audience. Try to understand your own, how you feel about doing these activities, and go in for active hobbies. So that's first thing. Active hobbies and hobbies that you will enjoy. Only by picking up those kind of activities is this going to be sustainable. Is this going to be long lasting, and you're going to see the outcomes, good results of that. And of course, avoid the negatives, like even passive smoking. Not just active tobacco use, but even passive smoking is very, very detrimental to the people in the household, right?
Right.
So yeah,
please go ahead.
So we want to be aware of this issue. So passive smoking also needs to be completely avoided. And alcohol in small amounts in moderation is usually not a big issue, is not a problem. But alcoholism or getting addicted to alcohol definitely has a lot of detrimental impact on the heart, especially alcoholic cardiomyopathy is a very well-known condition. So we want to stay away from that problem. Now, going on to the aspect of diet, we want to have a good, healthy relationship with food, right? Nowadays, it's become, either you love it or you hate it, or you kind of use food as a comfort kind of eating, as we call it. There is no healthy relationship with food. I think that is what is lacking. And we all need to understand that home food, like as it used to be, home food or food cooked in the house, let's say by ourselves or by our family members or somebody who's close to us. So this is how food has to be consumed. But I think we've all moved away from that, miles away from that. And if we can think about at least, let's say predominantly, if we are mostly eating 2 or 3 meals a day, at least 1 or 2 of those meals should be home cooked meals and wholesome, nutritious meal. And if not all 3 meals or all your meals, if one has to be outside, you might be working outside, you might be traveling out for work. So on average, if you get more meals, which is home cooked, healthy meals with a good proportion of all the ingredients. I'm not going to go into the macronutrients, micronutrients, but when we have fresh home cooked food, that's most likely going to have a lot of good ingredients in it as compared to eating outside or ordering outside. And if you have to eat outside quite often, then just remember that ordering healthy kind of food or choosing healthy options are always possible, right? That's important. And last but not the least, take time out for yourself. Okay, me time is something that I really believe in. I strongly talk about it to all my, let's say, my clients or my patients. Your time for yourself, right? This is not being selfish. This is not being self-centered, but it's extremely important to take time out for yourself, given that everybody is juggling a lot of roles and responsibilities in life. But about 20 minutes, let's say 15 minutes, half an hour, whatever time you can afford for yourself that you really enjoy doing things, if you can allot that time for yourself, it will make a huge difference. You will feel satisfied because that's the time which is under your control. The rest of the time, it might be that, you have to work for somebody or you have other roles to, obligations to fulfill. But when you have time to yourself and you decide that you want to spend it in a way that basically you should lose track of time. So it might be a hobby that you're doing, that you're engaged in. So try to do that on a daily basis. So start with small bouts. Again, baby steps are important. Don't try to do everything overnight and the next day suddenly give up everything. So just start with 1 or 2 things for a week. Try to see how it goes and then build up on those habit changes. And I think at the end of, let's say, a month or 3, give yourself about 2 to 3 months, you would have actually made a lot of lifestyle changes if you go at it systematically, slowly, 1 step at a time. I'm sure at the end of 3 months, you would have achieved a lot. But take it slow, be easy on yourself, appreciate yourself even for the smallest change. And no change is small. Believe me that even if I tell my patient have more vegetables or have more fruits, oh, that's a simple thing. Quite often my dietitian might think, or somebody who knows about it might think it's very simple. But somebody who's lived their life in a particular way for, let's say, 3 or 4 decades, you suddenly ask them to, modify even one small thing. It's not easy. So that's why I'm saying be easy on yourself. Take it light. Start enjoying the process. Yeah, and appreciate yourself. Have some rewarding system for yourself. It's not just kids that need, stars and whatever traces and all of that. Everybody do need this, right? So maybe if you or your spouse or your friends are working on it together, it's more the merrier, more the better. Then there's more opportunity to discuss, to learn more and motivate each other more and move forward.
Nice. I really like that most of the intervention doesn't cost anything. It just probably requires some motivation to start doing these things. And most of them are very simple tips that you can implement immediately. But of course, sticking to them is another story. But I'm sure this is going to be really a good start. I'll just summarize what you said, like move more make movement as part of your daily lifestyle, have active hobbies, avoid passive smoking, and have a good relationship with food, home cooked meals as far as possible, have some me time, and reward yourself for being good. You don't have to feel bad about rewarding yourself. So wonderful. These are probably where we should all start off with. Now I'm going to ask Shirisha Gijare. She's a PhD scholar in sports nutrition. And okay, I'm trying to unmute her. Yes,
Hello,
Dr.
doctor.
Shirisha, would you like to ask your question directly to Dr. Priya, please?
Yeah, sure. Thanks for
Can
the
you
opportunity.
switch on your video too?
Video, I'm just traveling, so I'm comfortable.
That's fine. You can ask your question.
Okay.
You can
So
introduce yourself once, Dr. Shrisha, and go ahead with your question, please.
okay. So I am sports nutritionist Resha. I'm currently working with Gopichand Academy, and
Nice.
I
Nice.
have been.
Yeah, great,
Thank you.
great, Shrisha. Go ahead.
So as a protocol, I am trying to test everybody's pulse and as a screening method. So 10 seconds pulse. But many children who are like, we have a varied age category, 8 years children, 14 years children and all. Physiotherapists and nutritionists work together. So physiotherapy doctor came to me with a syncope student, athlete. And when we checked his what I think he was malnourished as well, but his BP was very low, and I'm seeing low BP before activity. Nobody checks BP, whether we are doctor or I'm as a nutritionist. We somehow take granted that because we are from health profession, we may be healthy, but when I have tried checking my BP, most of the time, if we are not hypertensive, sometimes we are hypotensive also. So 90/60 was my BP. But then I tried to inculcate some changes and get back to my BP to some 100/70. So my question was, how recommended it is to advise any physical activity when you have low BP. We have some idea about if you are hypertensive, what care we should be taking, but hypotension is also as common as in at least my observation. So
Right.
and literature is comparatively very less, and like this session was God sent. I think I was trying to research the literature, but I saw this and immediately attended this session. Just
Wonderful.
5 minutes before I saw the
Sure,
WhatsApp.
Shrisha, so you mentioned that you are a sports nutritionist, right?
Yeah, yes, ma'am.
Wonderful. So you might be knowing quite a few. There are quite a few sports nutritionists in Chennai as well. So you are based where are you based?
Right now I'm in Hyderabad, ma'am.
In Hyderabad. Okay, so you brought up this important topic of hypotension. So first things first, a BP of 90/60 is absolutely normal. Okay.
Okay.
So in an individual who is healthy, who's not had any, let's say, dehydration or blood loss or anything like that to explain a low blood pressure, a BP of 90/60, I'm absolutely not worried about. So you mentioned you had a BP of 90/60 and you were trying some measures to move it up. But in general, how old are you, if I may ask, in your 20s, 30s?
No, I'm in 38. Nearing
Okay, you
40.
are in your 30s, fine. And you are also quite an active individual?
Yes, I'm active.
Active person. So let's clarify that first. So 90/60 is absolutely fine. If I were to take my resting BP, it's quite almost all the time less than 100 and less than 60. So I mean, you don't have to be worried about that. So hypotension is not a problem unless there's something underlying that is there to explain that low BP. So don't worry about that. But given the fact that you have a student, you said, who had an athlete who was complaining, who had an episode of syncope, that is something that needs to be evaluated. So I don't know if that low BP and that syncope were associated with each other. It might be or it might not be, but that syncope has to be evaluated with at least a resting ECG. A lead ECG needs to be done. He might have recovered fine. He might be feeling fine after that. But just a simple ECG. Is this child in the adolescent? What age group is this?
Yeah, he's a teenager. I think his age is 15 years.
Right, and that adolescence, that age group is very characteristic for when the conditions that we spoke about, cardiomyopathies or ion channel disorders, can actually manifest. So it's a good idea to get an ECG, and if necessary, have that run it through a cardiologist or an electrophysiologist. Ideally, for instance, sports screening is something that is now being commonly done in the West, especially if they're doing higher level sports, or at a very higher level, like league level or state level and things like that. But at leisure level, it's actually fine. Leisure sports, we don't do too much of training. But when it comes to competitive level, they need to have a screening, and of that screening, basic history and an ECG are the simple starting steps. So I think get that done for this child, and then if necessary, we can follow it up with other tests. But it might show up something, or it might be absolutely normal. But if necessary, we need to follow it up with a treadmill test. Again, a treadmill test is where you exercise the person and then take the ECG. So during that exercise, if there's something abnormal, it will prop up in those ECGs, and that will give us a clue as to if there's anything abnormal in this person or not.
Oh, okay. And we can advise physical activity in case.
You said this person is already an athlete, right? This child?
I was thinking to talk to his coach and ask him to give some rest or something like that.
No,
Till the things are sorted.
that is not necessary. If we can evaluate that individual, this might be the right time to do it. So stopping exercise is not a solution for any of the underlying conditions.
Oh, okay. And also, ma'am, gut health is related to any cardiology thing, because when I started topping up his diet, he had some issues with intake also, appetite or something.
Okay, so everything is interconnected, Srisha. So if you look at it, we are one organism, right? So gut health, brain health, endocrine health, all of these are interconnected. So we need to have this person completely evaluated. Yes, you might be able to provide some nutritional support, but in that process, we don't want to miss something else that might be potentially lethal.
Okay.
Thank you, Srisha. Thank you for putting your questions. In view of time, I'm going to get over to the next question. I'm going to mute you. Thank you for joining us again. So I think she brought in a very relevant discussion, and the importance of screening before doing any arduous or strenuous physical activity. I think all of us should consider that, whether they are children, young adults or older adults. If you're doing anything out of the ordinary, it is always better to screen yourself before you take up any activity. And I think that should become the norm rather than an exception.
Absolutely, yeah.
So this is a favorite question everybody wants to know. And it's been shot by Dr. Rajesh Prabhu. He's an eye specialist from Coimbatore, and he wants to know whether CT angiography and calcium scoring should be done routinely as a preventive checkup. It should. What are the benefits and what are the risks of radiation? Would you consider putting the entire population through these tests? What do you suggest?
Thank you for that question. So the short answer is no. I would not want everybody to undergo it. Is not a test. It is definitely not a screening test, right? So there are more problems that might arise from that. So if we can get the evaluation done systematically, and if we feel that let's say after the initial lifestyle assessment, the blood test, the clinical screening, and ECG, echo, so until maybe even a TMT stress test. So with all of these, we get a reasonably good idea as to whether the individual is of low risk, intermediate risk, or a high risk for coronary artery disease or an event, right? So only if we think that, and of course, we are also going to look into the family history, right? We're going to look into other parameters as well. So there are modifiable and non-modifiable risk factors. However, I will be giving a short concept introduction to epigenetics in a few minutes, but non-modifiable risk factors like genes and your, your origin as your Hispanic or Asian and all of that, your descent, and let's say your gender. All of these are technically non-modifiable, but now we know that even your genes can be modified by this concept of epigenetics. So let's not go into that right away, but the short answer is no, not everybody needs it, but if necessary, yes, you're going to look at the coronary arteries through the CT test is quite a reliable test with good sensitivity and specificity, and it's much more easier done. However, it is only a diagnostic procedure. It's not going to be therapeutic. So if we think there is a high chance of significant coronary occlusion, then it's better to get a proper coronary angiogram done in the cath lab, so that in the same sitting we could deploy a stent if necessary. So that's the advantage. But other than that, for screening or just to identify or diagnose, a CT test is quite enough. And the calcium artery, the coronary artery calcium score these days are quite relevant. They do give a good idea of, again, where this individual might be in the spectrum of risk spectrum, right? But again, as I said, for HSCRP, it's not that that one test alone is going to give us the entire information inside the Pandora's box. It's going to help us to identify those who are at a higher risk. So let's say a CAC of 400 or above, then we definitely know that there's a high risk, and then it might be worthwhile to even, of course, looking into all the other risk parameters, right? So please take all of them into consideration, just like how Shrisha was asking us, is the gut health important? Of course it is. I mean, if that is, let's say, we're not looking into an important aspect of, let's say, the person's renal health or gut health, or missing something that's going on apart from the cardiovascular health, and then if we just address this, it might just not be worthwhile. So we need to look at the individual as a whole. And I'm going to just share a slide at this point in time to talk about the concept of epigenetics itself. Give me 1 second. Yeah. So basically, we now know that even if we have a strong family history, let's say the individual has both parents who have had an MI in their 60s or 50s, then we know that at the age of 30s or 40s, this youngster is at a high risk for an MI. But what we also know that these are epigenomes, okay? So these are not single gene disorders. So only if the environmental factors also contribute, then this whole genetic problem or underlying mutation will actually manifest as a manifest disease. So it might remain subclinical, it might not even manifest. So what we are trying to say that is you might have some risk factors, you might have some contributing environmental factors, and only if all of these collaborate and cooperate, then this underlying genetic abnormality is going to surface and manifest as actually a, let's say, an STEMI, ST elevation, MI, or heart failure, and so on and so forth. So in short, we now know that non-modifiable risk factors like age, gender, and even genes can be overruled by a healthy lifestyle. So I think this would be the most important message for today. Yes, there are a lot of studies that say that at least 8 to 9 years or 10 years of lifestyle modification is necessary before these abnormal genes or diseased genes can actually wither away. But again, we don't know exactly how many years, but as we start making these lifestyle changes, these genomes, abnormal mutations will remain as epigenomes, meaning they will not actually manifest as disease. So again, as you see in this picture here, so you see that on the left side, are you able to hear me? Is there a lot of echo?
Yeah, I've muted the other audience audio.
So,
please go ahead.
Yeah, so on the left side, you see that there are a lot of environmental, dietary, and lifestyle risk factors. And then we have this epigenome. So that is going to manifest as either preclinical disease or increased cardiometabolic risk or disease. Only if these kind of risk factors are there for a prolonged period of time, and sustained so that actually these abnormal genes manifest into a disease gene itself. So again, this simple slide is just to remind our august audience here that biological age and chronological age are not the same, right? We all know that chronological age goes up every year. We can't do anything about it, but we have the control of our biological age completely in our hands, right? So then I'm going to stop share again there. So the answer to your question is, don't go too heavy on investigations right up front. Do a thorough clinical screening and go a bit light on the investigations and try to assess the individual more, try to propagate, lifestyle changes and all of that, and subject them to more advanced tests only if necessary. So these are for two reasons. You don't want to expose them, as you said, to the radiation risk and those kind of things. And again, we don't want to deny these facilities for those who actually need it by just screening the entire population, right?
I think that's very relevant to our Indian population because most of these coronary calcium scores and coronary CT angiograms, they're very promoted in the West. And I'm now reading literature where they're recommending for people in their 20s, and they're finding atherosclerosis as early as in the 20s for people who did not have cardiac events but were autopsied for some other condition, people who died in a homicide or a road traffic accident, and they found these young people with significant arteriosclerosis. And that kind of leads to the problem where you start investigating early. Even if you do find calcium, this is my understanding, that this is an event which has got over. It's not something which is a predictor, but it is an event where it has already undergone a plaque and calcification. Probably would give you an indication of the narrowing, but doesn't really tell you your absolute risk of undergoing a myocardial infarction in the near future. Do correct me if I'm wrong.
No, that is quite right. But again, calcification is a process or one step ahead compared to inflammation. So inflammation or inflammatory cells accumulating, let's say, inside the intimal layer of the blood vessels, this is one of the earliest steps that we now know. And then this is immediately followed on by calcium deposits. So these are all early stages of atherosclerosis as we are seeing it today. But we know that from the age of 5, it's normal process for these kind of plaques and even, atheromatous plaques to start developing. So they know that young mummies in the Greek world already had atherosclerosis in their first decade of life. So what are we going to do? As you rightly said, are we going to just screen all of them and start revascularizing them without having any, the heart probably is tuning in very well to all these changes naturally. It's compensating well. And that's why we say the natural bypass is a very important phenomenon. So natural bypasses basically are new arterioles and arteries which are being formed in the coronary vasculature just by exposing the heart to more and more, conditioning the heart to good exercise, regular fitness regimes, and all of those things. So instead of surgically creating a new bypass, the heart itself is doing it for itself. So it knows that in case in the future there's going to be a block somewhere, I would have my arterioles in place to compensate for it, right? So these kind of atherogenesis is going on a regular basis. We can encourage the heart to do more of that by leading a healthy lifestyle, and most importantly by proper exercise. Exercise and putting the heart under stress is known to be a good like a starting stage for this process of new arteries being formed. So natural bypass is what we want to aim for, right? We don't know at what point the heart might face an insult or an incident, and that at that point, if the heart itself can take care of itself, nothing like it. We don't need to go to the cath lab, the cardiologist and everything. But the other bigger problem that we are facing is we're all living longer because of all the medical advancements, but we're also revascularizing our patients very effectively, but we are not addressing the root cause. So people come back with second, third, multiple coronary artery events, and heart failure is again the biggest issue that we are having these days, right? People in their 30s and 40s with a left ventricular ejection fraction of 30 or 40, which is I mean, one of the worst things to have, because the quality of life is very poor when they have heart failure. So I think all of these are repercussions of unhealthy lifestyle, as we have been talking about for a long time. But if we can address it, it's never too late. So that's why we say cardiac rehab. Primary prevention or primordial is the best. But if we need to do it, we need to do cardiac rehab as soon as somebody has had a cardiac event. And if not, if we've missed the boat at that point in time, at least if we can do tertiary rehab, that is even after they've had, let's say, heart transplant or heart failure or any of the advanced treatments, even at that point in time, it's never too late. They can still modify their lifestyle to return to a healthy, life, and also to improve their quality of life.
So Dr. Ravi Kumar is the co-convener for the Wellness Committee, and he has raised his hand to ask a question. I'm going to unmute him, and then Dr. Ravi Kumar, can you hear us?
Yes, sir. Madam, sir, very, very useful topic. Late 50s and 60s, many patients are asking, sir, when I doing lifestyle daily activity, I'm very comfortable. I'm able to walk even 6,000, 7,000 steps per day. No problem. Even during normal activities, they find difficulty in climbing upstairs, or in a hill station, they find very difficult.
So sorry, you mentioned when they have problem with climbing stairs, or what was the
climbing stairs or climbing stairs, or any hill station. When they go in the hill station, when they climb in the normal road with the up steps, they found difficulties. But in normal activities, no problem. My question is it essential for the cardiac perfusion to be improved? At least once in a week, we have to give a kind of stress to the heart by treadmill, or any kind of vigorous exercise is needed, or normal walking activity is sufficient. Ignore the very rare crisis of dyspnea during climb ups and downs.
Okay. Thank you so much for that wonderful question, Dr. Ravi Kumar. So I think now we are going into the depths of it itself. But yes, first important thing is to get somebody evaluated, right? If that individual is able to do normal walking in flat ground, is actually fine. But when an individual has undue breathlessness or undue chest pain while climbing stairs, so one flight of stairs or two flights of stairs should not be a problem. So particularly people will say when they climb the metro, to go to the metro station or to the train station, I think in and around Chennai, they have to at least climb a significant number of steps. So one thing is they are up and about in the morning, they're in a hurry to get to work. So they've really been through 1 hour of, active stress mode, getting ready and, getting set for the day's work. And they're kind of running to catch a train, and they're also ascending up, let's say 30, 40 steps. So at that time, they might have their first pain or, first angina, and then they might feel undue breathlessness. They might need to stop for some time. They might not have had it in the past. Okay, so suddenly if something new is happening, new symptom, kindly do not ignore that. Get that evaluated. That is important. Your next question was, do they continue to, or do they need to, even if everything is normal, they've said, okay, cardiovascular wise, it's normal. Do they need to train more in terms of intensity? So what we call as, how do you assess your exercise regime is through a FIT principle, FITT. F stands for frequency, intensity, the time and type of exercise. Okay, so frequency, we all know, we do at least 3 days, 5 days a week. Time and type, we know our session is about 30 minutes or 20 minutes or 1 hour. The type of exercise, yes, we know we are either walking or jogging or let's say swimming. These are all endurance or cardio exercises, aerobic exercises. Some other types of exercises are your strength training. Let's say you're doing some weight training or core body workouts or, yoga and flexibility. So these are the different types. So what people usually have doubts are or not sure about is the intensity of exercise.
Yes, madam. Yes, madam. I want
how do you assess your intensity of exercise? The most basic way of assessing your exercise intensity is your heart rate, right? How high does your pulse rate go when you exercise? So again, Are we all measuring our pulse rate? Are we all wearing Apple Watches? Do we recommend that? No, we don't. So just like how you know that we feel breathless or not. So when you do a higher intensity exercise, then you feel short of breath. So there's a good correlation between your heart rate and your breath rate. So again, for lay people, the intensity is well identified by how breathless you feel. And there's something called the Bog scale, your perceived rate of perceived exertion, how much you feel you have exerted yourself. When I do 6 kilometers per hour in the treadmill, I feel it is a moderate intensity. My pulse rate is, let's say, around 120 or so. When I do 8 kilometers per hour, I'm actually running. That's quite fast for me. I feel quite out of breath within 2 or 3 minutes. That might not be the case with Dr. Aravind. He might be able to run at, I'm just giving an example. I don't know how fast you run, Dr. Aravind, but you might be able to run at 10 kilometers per hour for at least 10 minutes before you start even feeling short of breath. This is very individualized. Each and every individual will have a different level of intensity of exercise that they can actually perform, right? Because everybody is conditioned in a different way. So you cannot say it's like a one size fits all. So for each and every person, it is different. But again, they would be able to assess it themselves if you give them some understanding of it. So in our cardiac rehab sessions, we make education as part of our rehab sessions. We give them some health education every week so that they understand what is the theory behind exercise, what do we mean by a balanced, healthy diet. So I think I might not be able to fully do justice to your question by answering with all the details, but I think I've given at least some idea about how an exercise session has to be. So we say that at least 30 minutes of brisk activity every day is important on 5 days a week. So when we say 30 minutes, not just casual walking, brisk walking, where you're walking at a pace that you're actually not able to have a normal conversation. You're actually slightly breathless. So that is the pace that people should be walking in. And they should also combine it with strength training activities on 2 days a week. So this is the guideline that the World Health Organization has set for adequate exercise. So I think 150 minutes of brisk exercise per week in terms of cardio, and at least 2 days of 30 minutes of strength training exercise, either with equipment or using your own body weight, doesn't matter. But you have to strain, you have to be strong enough to be able to do more endurance exercises. Am I clear?
Yes, madam. We have to consider the intensity also. Because many of the articles did not mention about the intensity, just a lifestyle modification. But most of the literature, they don't concentrate on the intensity and cardiovascular pumping. They are now nobody is concentrating. So now what you said is very valuable suggestion, madam. So we have to concentrate intensity, increase the cardiovascular outflow. That is also very important.
Absolutely, sir. Thank you. Thank you so much.
If it is done, then only we can manage unaccustomed situations like climbing stairs or hill situations. Am I correct, madam?
Correct. So one important thing there you mentioned is hilly situations, places which are, let's say, hill stations. Again, this is a caveat because people with cardiac conditions should not be exposed to cold temperatures, and particularly they should not be exerting themselves in cold temperatures without the proper addressing the issue, meaning without medication or revascularization. If somebody with a compromised coronary arteries went to Kodaikanal and did some trekking, there's a good chance that they might have acute coronary syndrome as they're doing this, right? Because these conditions actually cause much more workload on the heart, and that is when the heart will not be able to compensate for when there are critical occlusions in the coronaries, and they might manifest with their acute episode at that point in time. So that's why we also stress the point that extremes of weather and particularly things like straining at stools or constipation, all these things are posing a much heavier load on the heart, and we have to be aware of these conditions in those who have already been diagnosed with heart problems, or for instance, as you rightly said, they might be at high risk, and when they're exposed to such situations might have their first attack or even may collapse at that point in time. So we have to be careful of these conditions.
Thank you very much, madam. Very useful. Thank you. So nice.
Thank you for your question, Dr. Ravi Kumar sir. Can you please introduce yourself?
I'm Dr. Ravi Kumar, ophthalmologist, Erode.
Right,
Oh.
sir. Thank you so much for your relevant question. I'm going to mute you right now.
Thank you, sir. Thank you.
So I guess everybody faces this situation. They're accustomed to a certain activity, but when they try pushing their physical activity to a certain high level, then they get decompensated probably. And it was a very a real eye opener that going to a hill station and doing a trek could probably open up a hive of possibilities. Basically, I understand you're probably stacking up your risk factors: high altitude, lower atmospheric oxygen pressure, you're climbing a steep incline, your compensated heart might just get pushed into decompensation.
Absolutely.
And probably breathlessness is something we should again pay attention to rather than just pushing it aside. So I think that was really put in place. So we are kind of at the fag end of the time that we've taken from you. So I'm just going to ask a very hot topic question again. COVID, right? After COVID, especially after COVID vaccinations, any sudden death has grabbed headlines. So what is your comment on cardiac disease or cardiac events after COVID disease or COVID vaccination? Is that relevant?
Again, a very good question. The coronavirus itself has both direct and indirect effects on the heart. So we know that it's a respiratory virus to begin with, but it is not restricted to the respiratory system or the lungs. So it can actually cause direct damage and havoc to the myocardial cells, to the cells of the heart. So that is why myocarditis, myocardial infarction, and even cardiomyopathies have all been increased in incidence during the pandemic itself, and indirectly as well, right? So as indirectly through inflammatory biomarkers and through other mechanisms, also the coronavirus has been known to affect the heart. And we all know that the comorbidities that already exist that has put an individual at a high risk for coronary heart disease has also led to several more deaths in individuals who have succumbed or who have been inflicted by the coronavirus. So yes, if you had a COVID infection in the past, as in you have been diagnosed and more so have been hospitalized or had steroid treatment or any other kind of antiviral treatment, please go ahead and get yourself cardiovascular evaluation done. Routine investigations, of which ECG and echo are a must, right? So this will be very helpful to pick up any underlying abnormalities, any heart failure, subtle heart failure, and so on and so forth. And about the vaccine itself, yes, there have been a few reports here and there, but again, the vaccine has been extremely effective in cordoning off the pandemic itself and, keeping the rest of the world alive. So I would not be worried about the vaccine at this point in time. So if you have not got all your 3 at this point in time, at least 2 vaccines, including the booster, please go ahead and get it, because the virus itself is now coming again and again in different forms and variations and mutations. Get your 3 doses of vaccine. Don't worry that, there have been a few reports here and there and maybe 1 or 2 celebrities, but that's because these individuals already were known with coronary artery disease to begin with. So don't go with the belief that, they're directly associated, the vaccine and the sudden death. So go ahead, be confident in getting your vaccinations. And if you've had yourself or family members have had the COVID infection, please go ahead. And if you've not screened yourself before, get the routine ECG and echo done, and hopefully there's nothing, but if there is anything, it's best addressed earlier. So I would say that a lot of the side effects of the pandemic, like being at home, being more sedentary, not being able to socialize, and a lot of mental and emotional stress, all of these have also led to the rise in coronary artery disease in the recent past. So I think it's a repercussion of multiple things, not just the virus itself. But thankfully and gratefully, we're all coming out of that, and I'm sure the future looks more optimistic.
Thank you for clarifying that. I really like the way you simplified so many of these concepts. You always have this fancy for the most expensive and the most fancy sounding investigation. But like you said, check your own boxes first. Do the basics, the ECG and echo first. Maybe start early screening. If you're taking up some vigorous activity, get yourself evaluated. If you have a family history, pay attention and get yourself thoroughly screened. It's not necessary that you go for the most expensive investigation available in the market. And just as a last question, we are kind of at 9 o'clock. This was asked by Dr. Shivakumar, who's another ophthalmologist. His question is, after a coronary stenting, after angioplasty and stenting, when would you recommend exercise? Is there a restriction on these exercises?
Great question. I think to close off, yes, in general, after a myocardial infarction, so if it was acute coronary syndrome and then revascularized with stenting, angioplasty and stenting, we would in general wait for some time. So now the window of after a interventional procedure is quite short. As soon as the patient goes home, they're ready to start back with their normal work life, their normal home activities. So we would say within a week or so they're ready for rehab. That's what the cardiologist also says. First get, but if you want to be on the safer side, couple of weeks, 2 or 3 weeks is actually fine. But somebody who's had a bypass surgery, we normally give them 4 to 6 weeks of recovery time, because it's, when I say bypass, I mean an open heart surgery, because nowadays bypass surgery is even being done robotically, minimally invasively. In that case, it's not even necessary to wait for a month. But if it's an open heart surgery, it's ideal to wait for 4 weeks before we actually exercise them. We could start the other components of cardiac rehab, like dietary modification and counseling, stress management, and risk factor education, all of that right up front. At the time of admission or hospitalization and revascularization is the best time to start the cardiac rehab without much delay. Exercise component, maybe the breathing component and the subtle components can start earlier. The actual aerobic exercise and strength training and all of that should wait until the individual is ready. So we do a simple 6-minute walk test to identify where they stand on the spectrum of cardiovascular endurance. It's a substitute for a treadmill, even a fancy test like a treadmill test. A 6-minute walk test on, just level ground will give us a clear idea of where they stand on their endurance, and then we start working on that. So yes, so the time delay, the shorter, the better. So in fact, we have had post-transplant cardiac rehab patients presenting to us within 6 weeks of heart transplant, and they have done very well after post-transplant cardiac rehab, right? So it is again very individualistic how they presented, what were the other risk factors and comorbidities, and then we start from there and build up on the exercise part of the rehab. But we take it as per the individual, very slow if necessary. Some people might be like, can we do it faster? I want to be back in the prime of my work life within, let's say, a month or so. That means to get them prepared for that, we need to be able to provide them more, physical exercise, more activities, get them up to speed. Some of them even finish 8 to 12 sessions within a matter of a month. But most likely they spend about 2 to 3 months in their cardiac rehab session. And that 3 months of lifestyle modification is actually enough to be able to sustain it for the rest of their lives.
Dr. Priya, I'd like to introduce Dr. Nirmal Frederick, our current president of the TNOA, who's been traveling, but still has managed to get time to attend our session.
Thank
and it's
you so
his
much,
visionary
Dr.
initiative
Wonderful.
in taking up these kind of very novel health-related issues and prevention. And he would like to ask you a question.
Sure, Dr. Nirmal. I briefly saw him coming in the car, I think from the airport as we were starting the session. And I'm really appreciative of the fact that you have taken this initiative, Dr. Nirmal, and best wishes for this initiative to be a huge success.
Thank you, Dr. Priya and Arvind, for that wonderful conversation on cardiac care. And it was very interesting questions, and really some of the illustration were really good. Actually, some of them even though we are medical people, I think from cardiac specialty perspective, we are still laymen. And of course, some of the questions would be very basic. And like Arvind said, it might be from a layman perspective. And I'm in Kerala now, and here people use coconut oil. We had a long conversation on the way about this. Here they use a lot of coconut oil, and I've been to Mediterranean countries where they use a lot of olive oil. And people say that olive oil is good, virgin olive oil is good. So is it really worth trying all these oils? Or kind of, I heard from one of the programs, just rotate your oils, don't stick to one oil. So
Wonderful.
what is your advice as a preventive cardiologist?
Thank you for that question, Dr. Nirmal. So this is one of the hot topics of discussion every time, anytime I give a presentation. So you gave the right answer. Rotation of oils is important, is good. The most important thing, or at least from what we know, any oil that solidifies on keeping in room temperature has a lot of saturated fat content. So we want to keep our saturated fat levels in our body low and go a bit high on the unsaturated fats, which are the healthy fats. So we know that butter, ghee, and all that would solidify in room temperature, right? So similarly, coconut oil. Of all the vegetable oils, coconut oil is something that we need to be cautious about, right? So in small quantities, it is okay, but in higher quantities. So, I mean, there are different thoughts or different ways of looking at coconut oil. Some people believe in just drinking coconut oil just like that. But I mean, unfortunately, we don't have enough evidence to show that it is very healthy. In fact, Kerala has been topping, as you see, with even Tamil Nadu these days in the number of coronary artery disease. So we want to be sure that we consume more vegetable plant-based oils. So that could be your groundnut oil, your rice bran oil, your sunflower oil, olive oil. Ideally, olive oil can only be used as a garnishing. It should not be heated. It is not fit for Indian type of cooking. But if you would like to garnish your salads or just have it with raw extra virgin olive oil with your whole grain bread, the important thing is, not to allow it to heat up, like not for our seasoning or South Indian kind of seasoning or cooking. It is not the ideal oil. So I would say rotation of oils is good. When we say rotation of oil, we mean keep 2 or 3 oils at home on a regular basis. So one oil for your nalannai, as we say, right? Your gingerly oil for maybe your dosas, maybe your groundnut oil or your other sunflower oil for seasoning or your bagar, and your olive oil for more garnishing. So when you have a combination of these oils, you get their good combination of mufas and pufas. And the key concept is minimal use. Even 5 ml of this oil has at least 300 to 400 calories. So we don't want to go overboard on that. So if we are a family of 4 or 5 people, we want to make sure it is minimal use of oil, not just too much use, and no reusing of any oil. That is the bottom line. Reusing, once we use it for, let's say, some frying, deep frying, then we don't feel like throwing it, we reuse it the next day. That is rich in trans fats. That's the most unhealthiest of all fats. So do not reuse any oil. First, do not deep fry. If you really want to deep fry, do it once, discard that oil, do not reuse that oil, and keep a few oils, healthy oils at home. Yes, you can use cheese and butter and ghee, but use them minimally. Use the vegetable oils, plant-based oils more liberally, but again, in small quantities.
Yeah. Thank you. Thank you so much.
You're very welcome.
So if those are the last of the questions, and we brought the session to a close. This discussion is neither exhaustive or not complete. There are definitely a lot more things and questions that we need to ask, but at least we've started a discussion. I would also like to announce a disclaimer that all these opinions expressed in this program are just a matter of discussion. They cannot be taken as a consultation. If you have specific questions with your health or your cardiac issues, please consult your physician or your cardiologist. You may also consult Dr. Priya Chokkalingam and the Cardiac Wellness Institute if you have further queries about preventive cardiac management or cardiac rehabilitation. So with that, we come to a close of this program. This is, again, one of a kind, and that it was completely interactive. Dr. Priya, you were kind enough to give your time and your expertise to the fellow ophthalmologists and also a lot of non-ophthalmologists who have been spectators ready to ask their questions about cardiac health. Thank you very much. I would also like to thank Dr. Nirmal Frederick, our President-elect, Dr. Arulmozhi Varman, next President, Dr. Sujata Mohan, Dr. Sriram Gopal, our current Secretary, and Dr. Balaji, our current Treasurer, the office bearers of the current TNOA, for having provided such a platform and given this opportunity for starting more discussions. There are more hot topics coming up in the coming few months. We are going to be talking about the next biggest killer, stress, hopefully in February, with your blessings and good wishes. Thank you.
Thank you very much. Again, a big thanks to all the organizers. And 2024 is a special year for us as Cardiac Wellness Institute. We have stepped into our 10th year. We're actually completing our 10th year this year. And no better way to start the year than being a part of this initiative by the TNOA. Thank you very much for this wonderful opportunity. And I'm really hopeful and looking forward to seeing, good positive lifestyle changes in most or all of our colleagues. Thanks again, Dr. Arvind, for thinking about me. You had asked me to do this session earlier this month, but unfortunately I was traveling, but I'm so glad I was able to join the session today. And I've seen a different facet of Dr. Arvind today, who is, adorned the hat of how do I get my fellow ophthalmologists to become more healthy? And I'm really appreciative of that. Thank you and have a
Thank
good.
you, Dr. Priya. And nice to see that the next generation is also taking up preventive cardiology. I've been a student of Senior Chokkalingam, and nice to hear and interact with the junior also. So thank you, Arvind, for taking this initiative and bringing in this format. It's very interesting rather than hearing the long lectures in the odd time. I'm sure this is also a heart healthy initiative, and I'm sure all our members, those who have missed, can log into TNOA website. So there will be a link available. All this will be available in the TNOA YouTube also. So this would be a very useful resource for all our members. So whenever time permits, they can go back and refresh or get relevant information. And so maybe next month, like Arvind said, we'll meet with a different topic and different set of speakers and panelists. So thank you, Dr. Priya, once again for sharing your time, expertise, and experience with us. And I think we should not keep it long, Arvind. It's 9:15. So once again, on time. So we look forward to meeting all of you or some of you during the trekking program initiated by the TNOA Wellness Committee. So this is again, we have our TNOA mid-year meet at Yelagiri on 27-28. And some of us have joined in this trek to Swami Malai. I think that will be the test for our heart strength as well. And also it will be a good time to get a fresh air and forest bathing. That's one thing we all miss in the concrete jungle here in Chennai or any big cities. And also, as ophthalmologists, we live in dark rooms and closed rooms. Most of the time we sit. Even our surgery is in the sitting posture. So definitely all these initiatives are needed for our own wellness, our own heart care, and also this will build up the much needed camaraderie among the ophthalmologists. So thank you all. Thank you, Arvind, wellness team, Dr. Ravi Kumar, and all the members. And of course, our TNOA office bearers, Dr. Arul sir, President-elect, Dr. Sujata, Vice President. She was she joined us for the welcome program. Dr. Sriram, who coordinated all these webinar arrangements, and all the office bearers and MC members of TNOA. So thank you all. Good night, and we'll meet in the next program. Next week, next Thursday, TNOA Thursday, we have an academic program for the exam going PGs initiated by Dr. Sharmila and her team, the academic committee of TNOA. So the flyers and the link will be sent soon. So please join us for next Thursday program as well at 7:30 p.m. See you all and good night.
Thank
Good
you.
night, sir. Good night, Dr. Priya.
Night,
Thank
Arvind.
you.
Good night, sir.
Thank you. Bye-bye.
Bye.